Up next, Glenn Hirsch is joined by Dr. Robert Eckel, Professor of Medicine at the University of Colorado in Aurora, Colorado. They discuss the ACCEL Guideline on lifestyle management to reduce cardiovascular risk.
Well, welcome, Dr. Eckel, to the ACCEL studio, and thanks for joining us.
Thanks, Glenn.
How does the lifestyle guideline fit in with the new cardiovascular risk guideline and other existing guidelines from the American Heart Association and the American College of Cardiology?
The lifestyle guidelines were created independently from those for cholesterol, obesity, and hypertension, and also those for risk assessment. The concept here was that the lifestyle guidelines would be gathering information that would be pertinent, however, to cholesterol guidelines in terms of how the diet and physical activity recommendations might best be used to lower LDL cholesterol, and secondly, also to be integrated with the blood pressure guidelines. Now, the blood pressure guidelines have taken their own path. They've gone independent from the ACC and AHA, and I won't speak any more about those, but we clearly covered issues related to salt intake as to how it altered blood pressure most effectively with the evidence that we groomed. I think it's important to point out also, Glenn, that the obesity guidelines were done entirely independently from those for lifestyle. So we kind of limited our look at the literature that dealt with clinical trials or meta-analyses that restricted weight reduction to less than 3% of calories. In other words, those studies where the primary outcome was either weight reduction or weight had been modified downward by more than 3% of the initial body weight. We excluded those trials, and those trials were either covered or omitted for other reasons by the obesity panel.
Why don't we get into some of the specifics of the guidelines? So what topics did you cover, and what sort of explicit take-home messages can we take from the guidelines?
The first issue before us was dietary patterns. We're really interested in the overall diet, not so much individual foods that people might consume. So dietary patterns would be things like the DASH diet, or ultimately the Mediterranean-style dietary pattern, the Western diet, etc. So these were dietary patterns we felt were conducive to meeting the needs of populations who are interested in reducing their cardiovascular disease risk by a nutritional perturbation. In addition, we focused in on saturated fat and carbohydrate, and ultimately dietary cholesterol and other types of fats, such as the monounsaturated and polyunsaturated fats. For blood pressure, we looked at sodium and potassium in the diet, and all of our assessments were carried out in individuals who were felt to be benefited by reductions in LDL cholesterol or in blood pressure. I think it's important to point out that our outcome was really modifying blood pressure and lipids favorably. It was not geared towards looking at outcomes of cardiovascular disease intervention. And the main reason for that is lifestyle-related research is not like a drug trial where you give a placebo versus a drug or even a drug at two different dosages to see what the effect might be on heart attack or stroke. These trials that were carried out were done over a certain interval, and we looked at a minimum interval of 1 month or longer, and sample sizes typically above 100 subjects who participated in the trials. And again, the data that we're reporting and ultimately leading to recommendations to follow were in patients, again, deemed to benefit from LDL cholesterol or blood pressure reduction.
So what sort of specifics? Obviously the diets in the last few years, we've had trials of diets, and there's probably a lot of confusion about the diets. And I didn't hear you say low-fat diet, which was always the standard that we were using. So what sort of specific recommendations came out about dietary patterns?
Well, we avoided kind of percent of calories from carbohydrate and fat because we didn't feel that that was well-founded in the literature. And the concept of the historic view of the AHA diet as being a low-fat diet was really dismissed by the evidence that we accrued. In fact, just to speak about the AHA's dietary and nutritional platform over the last decade, plus I think a few years past, would be that the low-fat diet has really not been evidence-based for that period of time. In other words, I think the low-fat diet is historic and no longer an appropriate diet for people to be on for cardiovascular disease risk reduction. So the dietary pattern is one that is enriched in fruits and vegetables and whole grains, nuts, legumes, and typically low in red meat, enriched more in lean poultry or fish. And this dietary pattern is consistent with that utilized in the Mediterranean, ultimately called the Mediterranean diet, or the DASH dietary program, which is a diet to address blood pressure mostly. But DASH itself has cholesterol-lowering benefits also. And also there's the sodium adjunct, too, to the DASH diet that we commented on further in our second critical question related to blood pressure control. So in other words, we're now putting an increased emphasis on dietary patterns. It's not good foods and bad foods, Glenn. I mean, have ice cream and birthday cake at your kid's birthday party. You don't have to confess that. It's kind of the overall diet that's consistent with that I just described.
It's a helpful clarification for anybody wondering what happened to that AHA low-fat diet type of recommendation. In terms of the sodium, obviously, with the diet, you're looking to lower LDL and the sodium potassium, trying to lower blood pressure. What were the goals or the targets for the sodium?
Well, the sodium issue's been a very controversial one, and I think in general, all of us are eating too much salt, and much of that salt is really in packaged foods, and it's difficult to avoid much of that sodium with the usual food fare that we purchase at the grocery store. So although the American Heart Association has recommended in its most recent series of recommendations a level at 1,500 milligrams, we found evidence to support that blood pressure lowering can be accomplished at 23 to 2,400 milligrams of sodium. That's a level of sodium restriction that's somewhere beyond a gram of restriction in terms of what our current intake patterns are. Now, if people can achieve 1,500 milligrams of sodium, in addition, of course, to a dietary pattern we deem as also heart healthful, ultimately they can get further reduction in blood pressure. We just questioned that the evidence at this time didn't support 1,500 milligrams, and a recommendation for 1,500 would be difficult to achieve by most patients. So we really went where the evidence was strongest to suggest that 2,400 milligrams of sodium is a reasonable level to achieve. And if you can get more, great.
Excellent. Now, obviously in line with giving dietary advice would be activity advice. What kind of advice was in the guidelines for activity?
Well, it's interesting that you asked that question, Glenn, because the physical activity approach was a bit different than that from the nutritional one. And that's that in 2008, the Department of Health and Human Services created a document that recommended physical activity guidelines for all of America. Now, that wasn't specifically targeted to cardiovascular disease risk reduction, but certainly included that among its recommendations. So we turned to meta-analyses and systematic reviews that had occurred subsequent to the 2008 DHHS report. And basically, we came up with data that continued to support those recommendations, where we're talking about 30 to 40 minutes of moderate to vigorous activity 3 to 4 days a week. And ultimately, that can be piecemealed throughout the week, or it can be done at several settings of enhanced physical activity. And I think the important thing to note here is that resistance training was not sufficiently capable of showing us data to support that as a intervention alone, but resistance training added to aerobic activity could be part of this 30 to 40 minute activity profile.
Excellent. Well, this obviously is a lot of ground to cover, and congratulate you on actually getting these guidelines out and helping us shape our recommendations to our patients. Which topics were not covered by this guideline?
Well, there wasn't time nor sufficient evidence to address certain very important topics that relate to nutrition and heart disease or cardiovascular disease in general. The one was the types of carbohydrate in the diet. Are simple sugars harmful more so than complex carbohydrates? And what's the balance that should be in the typical diet to really be associated with less CVD risk? We weren't able to address that because the data weren't sufficiently replete to be able to make a strong statement here. Now, keep in mind, diabetes was not our topic. Although we included diabetes in some of our analyses, clearly patients with diabetes who eat more carbohydrate may require more therapy. And so is carbohydrate bad? No. But in fact, does it require additional considerations by the healthcare provider? Yes. Another thing that we couldn't cover for the group of patients that we identified as benefiting, meaning LDL cholesterols between, let's say, 120 to 160, were studies that related to cholesterol content of the diet. Most of the studies on cholesterol, independent from the types of fatty acids in the diet, have been carried out in people either with normal cholesterols who would not need LDL lowering, or more historic data came from people with severe hypercholesterolemia, very, very high levels. But unfortunately, this specific question that asked the independent effect of cholesterol restriction from the diet in patients with LDLs between 120 and 160, there were insufficient data for us to be able to answer that question. So like any other process, it relates to guidelines. There are many other unanswered questions, unfortunately, that are still out there that need to be addressed.
It sounds like you're recommending a dietary pattern with a healthy pattern of food eating, which is more consistent with the Mediterranean or DASH diet, including fruit, vegetables, lean poultry, nuts, legumes, etc. Cut down on sodium, and as well as the saturated and trans fats, and engage in some sort of aerobic physical activity plus or minus resistance training at least 3 or 4 times a week. Is that correct?
That's correct, and that duration should be 30 to 40 minutes, Glenn.
Okay, great. Well, I want to thank you again for joining us and bringing us up to date on these important new guidelines.
Thanks for your inquiry.